Hey everybody, thank you so much for joining us today. We're going to give everybody a couple minutes to get online and get called in, but we will get started shortly. All right, hi everyone. Thank you so much for joining us today. We're going to get started. My name is Laura Cook. I'm here with my colleague Josue Melendez, and we work on the Multidisciplinary Responses to Families and Communities in Complex Homicide Cases project. This webinar was put together as a part of that project, and the Complex Homicide Project is a grant awarded by the Office for Victims of Crime, Office of Justice Programs, which is part of the Department of Justice. And we do have to disclaim that the opinions, findings, conclusions, or recommendations expressed are those of the contributors and do not necessarily represent the official position or policies of the U.S. Department of Justice. We will be taking questions at the end. Please type them into the Q&A box. If you are, if the webinar is up, it should be toward the bottom of your screen. It may be on the top or the side if you don't see it. But please do type your questions there. I will go through and read them in order to the panelists at the end. We should have some time for questions at the end of the webinar. So we are joined today by a multitude of speakers, and I want to take a second to thank all of you for joining us and sharing your expertise with us today. So first, we have Marina Duane and Sarah Batomsky from the Urban Institute. They're going to be discussing their work on another DOJ-funded project, the Center for Victim Research, and specifically, they're going to be discussing their research synthesis on losing a loved one to homicide. Following their introduction, we have Dr. Rynearson and Connie Saindon, who are going to discuss the restorative retelling model for co-victims of homicide. So with that, I'll turn it over to Marina and Sarah.
Thank you so much, everyone, and thank you, Laura, for the introductions. Everyone, we are very excited to be here. Thank you for joining. Just to give you quickly a background, my name is Marina Duane. I'm one of the co-authors on the synthesis and research work that we've done, like Laura said, on losing a loved one to homicide. And I also work at Urban Institute, and I'm a research associate looking at a variety of victimization topics. And I'm going to let my colleague Sarah introduce herself.
Yes. Hi, everyone. It's great to be here this afternoon. We're excited to talk a little bit about some of our research. So I'm Sarah Batomsky. I'm also a research associate at the Urban Institute's Justice Policy Center, and I do research and evaluation work around criminal justice policy, but with a special focus on crime victimization.
Okay. And before we dive in, I just wanted to say we are here representing the work of Center for Victim Research. If you're not familiar with us, we are essentially a hub for researchers and practitioners to come together and join efforts and to bridge that gap between research and practice on a variety of victimization topics. But today we will be speaking on the work that we've done for co-victims of homicide. So next slide, please. Great. So you will hear Sarah and me today referring to us reviewing research and practice, and very briefly just wanted to explain what that is. We've developed a systematic way to look not only at traditional research work and synthesizing those findings and then presenting them to you, but also looking at practice evidence as well. And that can be a little bit confusing, but we were very intentional in going to nonprofits to federal agencies that do work to support those who lose their loved ones to homicide, and then in a systematic way to analyze that work. And that gave us really a good opportunity to look at the differences, contrast, and compare where research is and where practice is. And also another disclaimer, we will be only talking to you for 10 or 15 minutes, but there is a lot of work that went behind this, and our findings are really complex. So we would encourage you to look at the report that we published, and also there is a brief available on the Center for Victim Research website, and I believe there will be links sent to you after the webinar as well. Next slide, please. So when we approach these syntheses, we always ask the same set of questions. We start with how many victims in our topic, how many co-victims does this affect? Then what are the risk factors? What are the harms and consequences that the people face? Importantly, what are the interventions in victim services and whether there are evaluations of those on the topic? And then we talk about policy, practice, and research implications. Next slide, please. For this topic of co-victims of homicide, we've looked over 500 sources. I believe it was actually quite a bit, much more than that. We decided that 319 sources were deemed eligible for coding, and so we had 147 research sources and then 172 practice documents and materials that we've looked at, and as I said, asked same set of questions to see themes. Next slide, please. I'm going to turn it over actually here to Sarah, who is going to walk us through the definitions, the risk factors, and harms and consequences.
Yeah. Okay, slide please. So after reviewing the evidence on both the research and practice side, like Marina talked about, our first step was to establish a definition that we would use for writing up in our report. So again, we reviewed the evidence, and we also spoke to subject area experts on this particular topic. We determined that the Center for Victim Research would specifically use the term homicide co-victims to describe this particular group of victims that we were researching. It's important to note that some of you may have heard of other terms that also refer to the group, such as homicide survivors or secondary victims of homicide, and they all typically refer to the same group. So drawing from both the research and the practice sources, we define homicide co-victims as people who've lost a loved one to homicide. This can include family members, but also other relatives or kin, as well as friends of the deceased. Slide, please. Our next step was to look at the prevalence of homicide co-victimization in the U.S. So it's important to note there aren't national prevalence statistics that are collected on this particular type of victimization. So our team looked at homicide statistics nationally to then generate estimates of national prevalence. So, for example, in 2016, there were over 21,250 deaths due to homicide in the U.S. This includes both criminal homicides, but also alcohol-related vehicular homicide or drunk driving accidents. So we took that number to start with, and then we looked at the research literature, and we saw that both research and actually the practice literature as well estimate that a single homicide affects 3 to 10 loved ones. So drawing from both sets of numbers, we used that to estimate that anywhere from 64,000 to 213,000 people lose a loved one to homicide each year. There was more robust estimates of lifetime prevalence of homicide co-victimization available in the research literature. And what that showed us is that across the lifetime, anywhere from 9% to 18% of the U.S. population will lose a loved one to homicide. Importantly, qualitative research and practice-based evidence also indicates that rates of homicide co-victimization are higher in marginalized communities that experience high rates of homicide. So those communities are particularly affected by this. Slide, please. So digging into the risk factors, and I'll just speak about these briefly. National studies indicate that Black adults and adolescents, as well as Latinx adolescents, face heightened risks of homicide co-victimization. Specific estimates of risk around this vary, but qualitative research also supports that there are these elevated risks for these groups. We also looked at a lot of practice-based evidence that suggests that Native Americans in particular are at an elevated risk of co-victimization as well. Slide. So I'll also speak a little bit about some of the harms and consequences that are faced by this group. And then next slide as well. So through our review, we identified 4 different categories of harms that are faced by co-victims, including psychological harms, harms to physical health, social harms, and economic harms. And because we're speaking for just a short time, I'm just going to focus on the psychological harms today, but we do have more on the other types in our report that we'll link to. Slide. So in terms of psychological harms, the research literature that exists on homicide co-victimization is the most robust in identifying different types of psychological harms. One of the most pronounced findings in this literature is that co-victims are at risk of particular mental health conditions. So about 1 in 4 suffer from prolonged or complicated grief. It's sometimes referred to as prolonged grief disorder, but it's a psychiatric disorder that's characterized by a preoccupation with and a longing for the deceased. And the rate among homicide co-victims is about 2 times higher than that's found among individuals who are bereaved by other circumstances. In addition, approximately 1 in 5 suffer from PTSD, and co-victimization is also associated with depression and substance use disorders. Slide. So just one last note about secondary victimization and different barriers to healing. So in addition to the different traumas and harms that are directly related to homicidal loss, there's extensive practice-based evidence that shows that secondary victimization is a particular concern to this group because they often come in contact with different institutions like the criminal justice system, media, social services, and healthcare that other mourners don't necessarily are not necessarily compelled to interact with in the same way. And in some cases, actors in those systems aren't necessarily prepared to interact with co-victims in a trauma-informed manner. Secondary victimization is also particularly harmful if it discourages co-victims from help seeking and receiving the support they need. So I'm going to pass it back to Marina, who's going to dive into some of the interventions and services for this group.
Thank you, Sarah. So next slide, please. So I'll talk a little bit about what we've seen, especially a lot in the practice review on services and interventions, but I'll also have commentary on whether we've seen evaluations of some interventions and where it's still lacking. Next slide, please. So like Sarah already alluded to, and probably not news to those of you who are joining the webinar today, the needs of victims, co-victims of homicide are really complex. They do have to address a lot of nuanced psychological harms that they're experiencing. They have to work with the justice system and through the confusing processes that exist within that while they're still dealing with the aftermath of violence, death. And then at the same time, they also have to deal with media and society. And what we've seen, I think, is a big theme here is that there are very few interventions that actually address the complexity of all those needs. It's going to look like today, we are so fortunate to have Connie and Ted talk about the efforts to really address them in a more comprehensive way, but we've seen that that's still missing in many places or for vulnerable communities. Next slide, please. Kind of intentional. Sarah already talked about psychological harms, but also I will be focusing a lot on what we've seen as themes through interventions that exist to address psychological harms. And I should say that all the other types of harms, economic and social, unfortunately, we haven't seen as many interventions, or at least they were not as well documented as the ones on psychological harms. And we've divided them into 4 types of groups. They're somewhat not arbitrary, but we've done that for heuristic purposes. I will just say that when I differentiate between these types of interventions, it doesn't mean that there is no crossover. So the first intervention that we saw a lot is grief support groups. They are the ones that, those are the groups that can be done by nonprofits. Sometimes it's law enforcement that offers those groups. But essentially, they are pretty accessible in the communities. They can be well advertised through different means and even signage on the street if it's a nonprofit. They can be cost efficient, and that's their strength. And in part, the reason they're cost efficient is because often they are offered free of charge, and they are led by people who have lost someone to homicide or to any other kind of death. We put mixed composition in both buckets, that is a limitation and a strength. On the one hand, if you're a type of person who is okay with being in a mixed group and you are okay that you lost someone to a homicide, but others might have lost their loved ones to natural causes, it might work for you. So for subset of population, perhaps it could be a strength, although the evidence is very mixed and actually limited on that. And then another advantage is that it is drop-in and drop-out basis, so it's open enrollment. It can fit with people's schedule and can be keep it as open doors. Not surprisingly, mixed composition we've seen from a lot of practitioners, from doctors, from psychiatrists, from researchers, saying that these mixed groups can be particularly challenging for co-victims of homicide because the dynamics of violent death are just really not the same. You're prompted to retell or relive the incident multiple times, and in many cases, it can do more harm than good. And I'm sure Connie and Pat will talk a little bit more about that. Another limitation of these groups is that there is lack of training specifically in violent death dynamics, and they're not that well researched. There is some, and it's isolated, but it's still not enough, especially on their impact on people who lose their loved one to homicide. We also wanted to highlight self-help groups. It's a little bit tricky to really figure out what it is, but essentially it's more organic groups that come up in certain communities that are affected by homicides a lot. We've seen some documentation of groups like Mama Circles in Chicago, where the mothers who lose their kids to street violence come together and lead these groups. And the strengths that we've identified were that they're responsive to the needs of that community because the people who are leading them are invested. They also are more targeted and focused on violent deaths, at least the ones that we were able to find in some cities where homicides are pretty high. However, obviously the limitations are that they are limited to those members who are aware of them. It's really not clear what is the level of skill among facilitators or how prepared they are to handle these groups. And then, obviously, they can be very difficult to sustain because we did not see any evidence that these are funded in a way that is sustainable. Next slide, please. I will be remiss to not mention individual or group counseling. I'm going to skip a few strengths and limitations here because I think a lot of us are familiar with strong evidence that exists that if you do access these services, they can have an impact on person, and it can be pretty good to, the evidence is strong to alleviate some psychological harms that people experience, both individually, one-on-one counseling, and some group interventions, such as trauma-focused CBT. Limitations are that we did see that for communities of color or where homicides are prevalent, these remain still inaccessible. They can be cost prohibitive because there is lack of insurance coverage. Sometimes they remain still stigmatizing. And again, it's really unclear how many professionals who offer help actually have training specifically in the dynamics of violent death reactions. And then, again, this comes from practice evidence a lot. Self-care was highlighted quite a bit by nonprofit organizations who work with this population. The strengths that were identified are that they build on all of our innate resiliency and ability to cope. And if you do exercise self-care, it can be a very quick means for you to reduce ongoing stress, and they can also be conducive to long-term coping skills. However, the limitation is that we don't know how much people pick up self-care, whether they are familiar, how much they sustain that. We also noted from some practitioners who said that it's really difficult to undertake after death or a sudden death, especially of a loved one, and research in this area is really, really limited. Next slide, please. And can you hit next one more time so that we can see the red dots? Thank you. So within the criminal justice system, as Sarah mentioned, people experience secondary or vicarious trauma, and as they go through these processes, they experience a lot of challenges engaging with people. So for the police, we've seen that FBI, for example, puts out a training for police departments to be mindful of how they respond when they deliver death notifications for the first time to someone. The training is very comprehensive, but we did not find evidence on how much police departments actually embed the training and whether it's sustained. Another theme, can you click next again? And next again? Thank you. Another theme of best practices in this area to make secondary victimization less prominent is that lots of police departments and prosecutors have embedded victim advocates, but I should say that we saw that quite a few practitioners pointed out that those victim advocates serve a variety of victims, and it's not like they have special training in serving those who lose their loved one to a homicide specifically. And then another limitation as victims work with the prosecutors is that on the one hand, they get support because really the prosecutor is there to represent their interests, but it can be tricky when if you are a co-victim of homicide and you want the outcome of your case to go one way and it doesn't necessarily align with those of the prosecutors, it can be a much more strenuous process. So there are some organizations that are putting out guidelines to prosecutors and the courts on how to make sure that the interests and the diverse wishes of those co-victims are actually represented. And then can you click next, please? I wanted to highlight the myth of closure. Often when co-victims of homicide go through this very difficult process, you can look at actually family members that are responding to what they want to see in the outcome of a case very differently. Someone wants to see the capital punishment, the other person doesn't, but a lot of practitioners are emphasizing that it's really important not to dwell on this myth of closure, because co-victims who have gone through the process often report, and there is actually really good qualitative research supporting this, that the closure never may come. So taking someone and promising that closure can do more harm again than good. So that's another best practice that is highlighted, but again, it's unclear how much the criminal justice agencies are actually following that and the extent of it. Next slide, please. Next slide, we're going to skip this one. It's a great quote, but I want to be mindful of our time. So just very few messages about where the field needs to grow, and I'm going to turn it over to Sarah.
Okay. And we'll just briefly close now because we know we're running up against our time limit. So in terms of where the field needs to grow, On the research side, there are a few studies that have examined individual or household level and also community level risk factors for homicide co-victimization. We also urgently need up-to-date national estimates of prevalence. There is a lack of information on risks about specific vulnerable groups, particularly Native Americans, and there are few studies on physical health and economic well-being.
Next, and we can skip that slide. Next slide, please. And just on the policy side, we still have a lot of work to do with victim compensation. Depending on where you live, we see that there is a lot of variation on what gets covered and whether you're going to get actual financial assistance to cover the costs and offset the costs associated with losing a loved one, like funerals and other material things. And then insurance coverage remains an issue, especially among the vulnerable populations, like I mentioned. And I think with this, we are going to close because I really want to make sure that we have enough time for Ted and Connie to walk us through the restorative retelling. But thank you, everyone, and we look forward to your questions.
Thanks so much, Marina and Sarah. So their contact information is up there on the screen for you. I believe we're also going to try to distribute after the webinar some resources, including their, I think a two-pager or something similar on their synthesis. It's really, really interesting, and I think a lot of our partners, a lot of the sites that have been working on this project with us would be really interested to see that. So next we have Dr. Ted Rynearson and Connie Saindon. I do briefly want to say, while this webinar is on the restorative retelling model, it's not a formal endorsement of the model. We don't really know what the best support group model is or if there's one that everybody should adopt, but we're highlighting this one for a couple reasons. One, because it is one of the few support group models specifically designed for co-victims of homicide. And secondly, a few of the project sites that we've worked with have actually already been using this for a while or have used it in the past as one way to support families after homicide. So we thought it would be an interesting model to highlight. And I'm glad that Marina and Sarah talked about some other models as well. So with that, we thought it would be good to hear directly from the developers of the model, and I'll turn it over to Connie and Ted.
Connie is muted.
Welcome, and thank you for joining us. This is Connie Saindon. I'm both a mental health professional and a co-victim, as I had a sister that was a murder victim in 1961. I began to specialize, though, in working with this population in 1995, after 20 years of a successful private practice. I was really interested in something that made the lives of co-victims more manageable, as I found traditional bereavement inadequate. We do not want our families to deal with this alone, and neither should we. And none of us have all the answers. Thanks to the Victim Research Center for expanding our knowledge and connecting us to each other to doing this difficult yet rewarding work. Thanks also to Dr. Alyssa Reingold, Director of the Crime Victims Research Center in South Carolina, who was instrumental in publishing our research, showing that we were making a difference. One of my greatest influences has been the restorative retelling model developed by Dr. Ted Rynearson. When asked to do this webinar, I invited him to join us. He will provide you with an overview of his work with restorative retelling. I will follow with my work with incorporating co-victims of homicide with that model. In this section of the webinar, I have worked to introduce ways to incorporate restorative retelling, considering all your different positions. And just to note, I use the term co-victim and survivor synonymously. At the end, we've added a resource section that includes our contact information, consultation and training opportunities, books that will be useful for you, and a partial list of colleagues from across the country whose important work has influenced us and Their work has been influenced by restorative retelling. Dr. Rynearson, thank you for joining us. Next slide.
Connie, thank you very much. And also, I think, for that very solid introduction about research and practice, which is a good way to begin. And I'm going to shift gears a bit because I think what we need to focus on in terms of both research and practice is to get a bit experiential. Because if you begin working with a family member after homicide, you're going to be plunged into an ambiguous, ill-defined, sometimes horrific sort of story that the person with whom you're working is beginning to approach. You're talking about vulnerability psychologically. I think the people who are most vulnerable are mothers who have lost a child because of the intense attachment. 4 to 1 in terms of primary family members. It's almost 4 to 1. Mothers outnumber anyone coming in and asking for assistance. And usually it's around 9 to 12 months after the homicide. So that we have focused with our restorative retelling model on working with family members, not just during the acute phase. And at that point, I don't think they need psychological sort of intervention. I think they need first aid, psychologic first aid and reassurance and information, which I think is provided very well by most local resources. But it's 6, 9, 12 months later when they can't work through their own traumatic response to the dying. It's those symptoms that form a syndrome that I'm going to describe that bring people in for treatment. But to begin, Connie and I are both have experienced a sudden violent death. My first wife, Julie, died in 1974, not from a homicide, but from a suicide, which is a different form of violent dying, and to some extent even more complicated, because the perpetrator and the victim have disappeared in the same act. She'd gone through a very severe prepartum depression with the birth of our third child, Wendy. She was still in treatment, and her depression became even more intense after Wendy's birth, and Wendy died suddenly from an intracranial hemorrhage when she was a month old, and Julie committed suicide a week later. So as a psychiatrist, I found myself a participant observer much more than a clinician or a researcher, having to grapple with my own, what I began to appreciate was traumatic grief beyond complicated grief. Traumatic grief meaning that there's a traumatic dimension to a sudden external dying that isn't captured by the models of complicated grief. So I began volunteering as a consultant with some of the support groups in Seattle, where I've been working as a clinical professor of psychiatry at the University of Washington, and also started a section of psychiatry at a Virginia Mesa Hospital and Medical Center here in Seattle. So I began trying to develop some guidelines, not only for group therapy, but for a shorter term closed group model rather than an open group, because I had a lot of confidence in group therapy. I've been dealing for years with group therapy. So we began a project in 1984, which is still going on, for traumatic grief after violent dying. And we have worked with over 300,000 adults since that time. So we've had a lot of clinical experience, and working a research model into this sort of population and practice is very challenging. Family members usually aren't willing to come in until 4 to 6 months after there's been a violent death, so that in terms of the levels of distress and the vectors of the distress measures, we can't really begin measuring anything before 4 to 6 months, usually with any research. And I'm not persuaded that number of the measures that we're using, the standardized measures, like the Beck Depressive Inventory and Marty Horowitz's Impact of Event Scale and Holly Priggerson's Complicated Grief Scale, are important reference, but they don't really measure, I think, what's also clinically significant is the very complex narrative that the person is retelling after there's been a sudden violent dying, particularly homicide. So what we featured with this center has been free service, which has been supported through grants and donations since 1993, and we've received VOCA funding from the state of Washington. Then we began doing trainings, local, nationally, and international trainings. The University of Washington began supporting work that I was doing in the Middle East. And so there have been restorative retelling interventions that have been set up in Gaza, where I visited Israel, Jordan, Lebanon, Syria, when I could still get in. And some of those groups continue to run. And in '99, we developed a intervention manual, about 60 pages long, which you can download from our website, which is at the top of this PowerPoint, at no cost, so that you can follow some of the details of the intervention if you want to. We've applied this model at multiple sites, including prisons and major cities in the United States, by bringing teams of clinicians out to Seattle for the training. And that's really how Connie and I began working together in 1999 when she came here for a 4-day training that we had sponsored through OVC. There have been publications, a couple of books, and recently refereed articles that allow us to enter the kingdom of the evidence-based because of the pre-post measures that we're using, but these are outcome studies. This is not research in the sense that we have a control group or that we're comparing the intervention with other interventions. So it's rather rough in terms of our research, but I think meaningful in that it's a pilot study that confirms that these measures show a significant decrease at the end of a 10-session closed group. And we have some follow-up at a year suggesting sustained improvement. We have a very low dropout rate of around 20%, which is a good sign, I think, of the intervention in the right hands. And Connie has been running these groups for since 1999, and she's going to go into the particulars of the group intervention. But before that, I wanted to talk a bit about the narrative model of traumatic grief after violent dying. And that what I was going through, and anybody after there's been a homicide of a close relative or friend, is battling with two conflicting narratives. The narrative of the living attachment with the person who's been loved, which is close and nurturing and comforting and alluring, counterbalanced by the image of the way that they die, which is often horrific. It's an image of helplessness. It's an aversive image that occurs intrusively rather than more persistently in an alluring kind of interchange. And this is what I've found myself going through initially. And I think most of the time, this is not only normative, but clears up spontaneously within several months. These kind of images as flashbacks, as dreams. And it doesn't require a formal sort of intervention. But particularly with mothers after they've lost a child with homicide, they're trapped in this image of dying because somehow they have to enter the image to rescue the child, to make all of this happen because of their caregiving obligation, which I think is what complicates things for mothers. So this is basically what's underlying the model, is a narrative reconstruction of not only the relationship with the person, which you're very familiar with standardized sort of grief therapies, and that's usually related to the level of attachment. But counterbalancing that is the narrative of the way that they died and which should be approached first. And why do people drop out of the standard kind of therapy? And it's often because they haven't been stabilized with this traumatic sort of narrative that they've been left with. And you don't want to get into that narrative too quickly. If there's been anything that's common to short-term trauma and grief intervention, is that it occurs basically in 3 phases. The first is stabilizing the person in terms of the level of trauma, even with natural dying that they're experiencing, followed by some sort of restorative re-exposure, where they're not only dealing with the commemoration of the person, of bringing that memory back to life, and doing that before you begin working on the reenactment imagery of the dying. And a third phase is one of re-engaging people with life outside of therapy. And that often involves, in our intervention, actually bringing family members in for one of the sessions. I wanted to present then, before Connie begins talking about some of the specifics, some clinical principles that will help you, I think, with individual therapy or group therapy. First is the understanding that grief is more of a reactive syndrome than it is a disorder. It's a response to the death of a loved one, and it doesn't occur unless there's been a level of intense attachment. Sociopaths, people with intense narcissistic disorders, we've been hearing about a lot of that recently, haven't we? Really don't have the capacity for an empathic sort of involvement with somebody that they love, whose presence is as important to them as they are to themselves. There's something altruistic about the attachment. So sociopaths and highly narcissistic people, or some borderline patients, are very important to screen before you get into any sort of intervention. And of course, this was driven home with a lot of the work we are doing in prisons, where chemical dependency is another complicating variable before you get into any kind of intervention. Secondly, there are no discrete stages with traumatic grief. Instead, there's a before and after. There's a stage of what you were like before this happened and how you are now. And how you are now is something that can vary from minute to minute, to hour, day to day. It comes in waves and oscillations between these stories that you're telling yourself and your future. It's also sort of a rite of passage that family members go through with any kind of grief, a natural dying or a traumatic dying, and that their identity to some extent needs to change. Who I was before and what am I now that I don't have this important memory and person attached to me. Third principle is that treatment takes time. Time for listening and retelling and reframing and redefining oneself in the face of these narratives. And of course, there's precious amount of time available now with what's going on with our psychiatric insurance. Not only that, but with psychiatric training. I'm a dodo bird when it comes to psychiatric training. I trained about 60 years ago, and psychotherapy and psychodynamics were a part not only of my training, but of my practice. And nowadays, there's much more of a focus on neurobiology and medication. And one of the things we know from carefully done, prospective, double random assignment, double-blind studies is there's no pill for grief. This has been carefully researched. Antidepressants do not help. That's important to recognize because a lot of the people that you're going to see are already on them because their local physician has sort of reflexively started them on with a diagnosis of depression when it's related more to the grief, which is a different order of problem. And the last principle is that there is a neurobiologic correlate to grief. When I was a real doctor many years ago and on a surgical service, I would have to deal with patients that were about to go through a physical amputation of an arm or a leg or some part of their body. And I would spend time with them the night before the surgery, preparing them for the fact that when they woke up, the presence of the limb, whatever had been amputated, would still register. It would still be there. They could feel the leg, light touch, position, temperature, sometimes pain. And that's called a phantom limb. And the neurologic explanation for that is that that aspect of their body registers centrally in the brain. And we even know what part of the brain is responsible for body schema. Interestingly, infants who are born without limbs have phantom limb phenomenon. And the phantom limb phenomena never disappear. They moderate, they diminish. But what's been dismembered continues as a phantom. I think in rough terms, there's a similar correlation between us and being amputated from someone that we love, who's an important part of ourselves. So we are dismembered from a child who's been killed in a homicide. And rather than registering that absence in terms of physical symptoms, it's registered in terms of memory, narrative memory. And we try to remember what has been dismembered from us in terms of the relationship. And not only the loving relationship, but also the traumatic narrative that has to be told over and over again. So I think there is a neurobiologic basis for what people are going through after traumatic grief in terms of all of this registering within the brain. I want to emphasize that there is that sort of basis, but we don't recognize the details of that, and it's not clinically relevant. None of the studies that they're doing on MRIs have any clinical relevance whatsoever. I think what helps is retelling, becoming joined in this narrative. Could I have the next PowerPoint? And this is a sort of a narrative dynamic of what goes on with natural death on the left-hand side of the screen, which is about 85% of deaths are natural, and sudden violent death on the right-hand side of the screen, which is around 5 to 10% of annual deaths. And the narrative dynamic with the natural death, the family members has an opportunity to interact with the person as they're dying, so that there are themes of rescue, of reunion, of respect, of relinquishment, and the family member has an opportunity to enact the dying narrative with the person who's dying from a natural cause. There's time, there's space, opportunity for action. And the person who dies was not alone. The family members has an opportunity to actually be there, trying to comfort the person, even in the terminal moments. Very different than the inactive role of the family members when there's been a homicide, which is to witness this surreal replay of what the person must have gone through. This is what I went through with Julie. I could not be there at the time that she died. I've tried to have rescued her, but I was left with the narrative of what was she thinking, what was she feeling, what were her last words. And these are, I think, reflexive, sort of inactive themes that are forced on a person after a violent death like a homicide, of reenactment, of remorse, revenge, retribution, recurrence, because this is a dying that never should have happened. So that the media is there, the police is there. There's a whole other story that needs to be processed, not just the private story of our attachment to the loved one, but the story that the courts are telling. I wanted to go on to the next PowerPoint and the one after that to save time. This is the dual process model of grief. which I think is very helpful. This was developed by Maggie Strobe, who's a research psychologist and clinician in Europe. And it refers to what I've already talked about, which is this sort of oscillation that people go through with grief between the loss-oriented and the restoration-oriented identity that they're struggling with. Different images of themselves in the future. And having to oscillate between these images of the loved one and the separation distress, the pining, the searching, the resurrection of the alluring memory of the person in a relationship, and beginning to, and resisting breaking those bonds of being close, and the denial that anything is going to change. Now, the challenge, of course, is to restore themselves to a new identity, attending to life changes, doing new things, new roles and relationships. I think is a very helpful sort of model rather than stages, and that this goes on forever, really. The loss-oriented polarity becomes less manifest with time, but never disappears because it's part of the whole phantom experience of grief. And the next slide. And this is how I think violent dying-oriented polarity can overshadow and complicate the loss-oriented. Rather than separation distress, there's additionally trauma distress to the horror and helplessness of the dying. And rather than having just resurrection fantasies, there are reenactment fantasies which are intrusive and not alluring. And really the challenge is that breaking bonds of caregiving, not only care seeking, but talking about mothers and children particularly. And that change is nihilistic. I mean, how can you ever comfort yourself or find meaning in a homicide? It is a dark, black hole. You can't find meaning in it. And everything needs to shift from the left side of this model to the right. But often we have to bring back the imagery of the loss-oriented before we begin dealing with the violent dying, because the loss-oriented offers a pole of stability that you can work from. So it's important not to get into the violent dying orientation too quickly. Let me see the next PowerPoint. This is an image of resilience. Before I talk about that, let me just mention a few clinical principles when you're working with somebody after there's been a homicide. With the first interview, you've got to reinforce resilience before retelling the violent and the dying reenactment. When I'm seeing somebody for the first time, I often know that they've lost somebody from a homicide, but I reassure them that it's the last thing we're going to talk about. I need to know the person's name. I need to see their picture. Are you still having conversations with this person? Is their voice comforting? About 60% of family members are having active conversations with their loved one after a death, even a violent death. Who takes care of you? What are your beliefs about Fred, if that was his name, after death? Spiritual sort of resources of resilience are crucial, particularly religious sorts of beliefs, which need to be summoned and reinforced. Sometimes, of course, religious beliefs have been challenged by homicide. Finally, what gives you hope you can change? And how do you want to change yourself? These kind of questions before you begin doing any kind of trauma work. And finally, this is my image of resilience, of being balanced on a lot of forces that we can't really define, but we're being swept along by. In terms of the neurobiology that's going on underneath this precarious position that we're in after a death, It's a perfect model for a psychiatrist because I can only see the past, not the future. And when I got into one of these boats, or used to, it weighs 38 pounds and is 11.5 inches wide. And it takes all of my concentration just to balance myself and to get into balance with the forces around me, rather than struggling with the narratives of being able to begin processing them in different ways. Of course, we could put a motor on the back of this boat, like it was a psychotropic medication, or a sail, and as if it's cognitive therapy to blow you one direction or another. But you've got to be able to balance yourself, to have future hope in the future, and know that you can get back to the safety of the dock. All of those principles, I think, are important to respect in early work. And this is my final PowerPoint. Yes. And this is to show you that all of us go through changes when it comes to resilience. I can't get into that sort of boat anymore, but I have a different kind of boat. And these are two of my 7 grandsons who are now taller than I, which I think is a nice way to end my part of the presentation. And Connie, take it over from here.
When I think in terms of restorative retelling support for co-victims of homicide, I think of 3 major areas of focus for us. Certainly psychological, which the intense emotional extremes puts one off balance. The other area is psychoeducation, the ignorance of the justice system, media, victims' rights, and so much more. And empowerment in a sea of powerlessness where one does not appear to have a role. Next slide, please. Homicide adds many complex demands on co-victims and those who serve them. Other speakers before me have alluded to some, and I'm going to reiterate some as well. Very different than a death by many other ways, this one gets extremely complex and complicated. The first thing the family gets introduced to is a lot of new people and agencies that they've never heard from before in their life. Homicide detectives, paramedics and EMTs, medical examiners, the media, many forms of media, including social media, victim advocates, who are they? What's their job? Cleanup services, some of our families don't even know they exist. Prosecutors, certainly employers and schools get impacted in their own ways and policies and procedures, as well as our faith communities who have their role and purpose as well. Defense teams, some who try to trick you into thinking they're officers of the court and on your side. And unbeknownst, they're interviewing you and you don't know the difference. Cemeteries and other sorts of issues. I'm sure you can think of many other agencies and personnel that our families get involved with. And of course, there's multiple levels of complexity. Some cases are murder cases, some are capital murder, some are manslaughter, some are negligent homicide. Dr. Rynearson mentioned suicide. That's a self-murder to many of us. Could be a drunk driving fatality, a shaken baby death, a gang killing, a terrorist fatality, like we honored yesterday. Could be murder-suicide, which never sees the courtroom. In some cases, there's no body ever found. Some, there's multiple suspects and multiple trials. Some cases are serial cases. Sometimes in 20 years after the actual death. Sometimes there's no suspect. Or sometimes there's a suspect, but there's not enough evidence to go forward on the case. Sometimes it happened in another state. One mother had her daughter killed in Alaska, and she lived in South Carolina, or another country. One family lived in San Diego, where our program is, and their family member was murdered where they lived in South Africa. Killer not found not guilty. So many complexities, and I'm sure that you could list many too. But all of these add to the complexity and the strain for our loved ones. Next slide, please. Let's take a look at the difference between a natural death and an unnatural death. A murder is violent. The act of dying is injurious. It's also a violation. The act of dying is a wrongdoing. It's volitional. The act of dying is willful or an act of irresponsible negligence, which is one of the hardest things for our families to adjust to. And of course, I've mentioned before, it's voyeuristic. The media, one's private life becomes public. Next slide, please. Co-victims of homicide are at risk, as we've heard before, post-traumatic stress, depression, and substance abuse disorders. Oftentimes, they're referred to a grief group that doesn't meet their needs. Therefore, our work begins with screening. We want to look at what's happening with them psychologically before they begin, and we can recommend different levels of treatment. And the screening that we do is 2 months at least after the loss. If we did these screening instruments in the very beginning, we'd get very skewed results. But we want to see what's happening with their depression, so we ask them to fill out the Beck Depression Inventory. We also look at what kind of images, what are they seeing and playing over in their mind that is adding to their distress. We measure for complicated bereavement and post-traumatic stress. After 10 weeks or 10 blocks, 10 sessions, we do the screenings and ask them to complete them again. We continue to monitor their progress and help them to see how they're doing as we move along. Next slide. We also need to look at the impact on family and friends. We have this idea that the people in front of us, oftentimes 1 or 2 people, are the people we attend. And yet there's a lot more people that are significantly impacted. One person says it this way: my father had 4 strokes, one of them major, from the time of the murders till the arrest was made. Another says, my daughter's friends were broken and confused and their lives were in shambles. They had no rights. Their pain and fears were just as real as yet society could barely deal with me, much less the ripple effect of murder. And one other person says, my mother blamed me for the murder of my sister. No one in my family got help. Next slide, please. The task, as you've heard Dr. Rynearson mention, is to reinforce resiliency after trauma to counterbalance. Trauma is the combined experience of terror and helplessness, which is both aversive and intolerable. Resilience receives and holds the emotions of trauma within tolerable limits. Next slide. We need to counterbalance our observations too. For those of us who are working in this area, we're trained to look for problems, disease, disorder, weaknesses. It's our job to help fix in some way within our scope. Restorative retelling offers us a way to also look for the opposite. I like to say, what do our co-victims have going for them? What is already in place? Everyone has resilience, and it's up to us to notice and foster it. Restorative retelling invited me to do that by its emphasis on our innate abilities, our resiliencies. Next slide. In 2 of the studies that I did of comparison of those pre and post scores, the data shows a highly significant decrease on all measures of distress. That has been very promising. Next slide. Treatment consists of individual support, and time-limited closed adult groups. Restorative retelling and criminal death support, 2 different groups. They're conducted with 10 weeks, 2 hours. They're closed, which means after 2 sessions, we don't invite new people in. We want people to be able to work and be comfortable with one another over time. They will compare their story with each other's story, and one story will be worse than theirs and one will be better than theirs. They follow a sequential course, and we usually have about 10 participants. And it's confidential to build up the safety that they can to open up with each other. Next slide. Being with others in a group cannot be understated. They can share things with each other that those of us in clinical work cannot share. Some of us have agencies where we're restricted with what we can and cannot say. These folks can share with each other important things. One survivor says it this way: it's extremely useful not only to hear oneself, but also to hear others who are experiencing similar trauma. In group, I learned that in working my way through tragedy, anything goes as long as I don't do lasting harm to myself. I also got bits and pieces of knowledge from others with other cases regarding legal processes. Next slide. Restorative retelling is facilitated by this partial list of questions. We'll often use 2 questions per each group session of 10 sessions. And they will go like this. One of the example is, what happened? And like Dr. Rynearson mentioned, asked very infrequently. And in the 10-week process, we only ask the first session to reduce the traumatization and the getting stuck in their death story. Another time we'll ask, what are you doing specifically when you are not immersed in what has happened to you? We really want to foster those small parts, perhaps, that they're doing that we can encourage for them even more. At another time we'll ask, what's changed? Oftentimes their entire world has been thrown upside down. And how have you prevailed? We're looking for both the strengths and the negatives. Another time we're going to ask, who's been your support? We want to know how alone this person is. Also to acknowledge that sometimes what they found is that some people have been there and some people have not. People that they thought they could count on that would be there are not able to be. An important question we ask is, who was your loved one? Not what happened to them and what's going on with the case. What did they like? What do they do? What do they eat? What's their favorite food? Is there a favorite joke that they played? What was it that they valued, and so on? Another important question that we ask is, what is it that you cannot forget? What do you keep seeing, keep playing in your mind? Next slide, please. The restorative retelling interventions that we look at, those that I encourage you to diagnose resilience in the service of reducing those symptoms. Innate resiliencies, things that we're born with, these abilities that guide our work. One is pacification strategies, and that is the ability to calm oneself down. We know that infants calm themselves down by sucking their thumb or rocking. We want to look at what are these people able to do to quiet themselves. And partitioning strategies, that is the ability to separate from others and events. When we're born and growing up, we have to figure out that in time, mother is a different person than we are. In the beginning, we are oftentimes merged. We don't know the difference. After a murder, many of our family members merge with their deceased person. It's as if they were murdered too. And it's our job in different strategies that we help them to recognize this and separate the difference. And the third intervention that we use is perspective strategy, which is the innate ability to have hope for the future. Many of our families start out and stay there for a long time, not having any sense that there'll be joy in the future, that they'll be able to live with this story and also have a sense of the hope for the future. Next slide, please. Here's an example of some of the pacification interventions, the ability to calm oneself down. We end each one of our group sessions with a relaxation, a calming activity. We do breathing exercises, helping them to know that just relaxing and breathing sometimes in a slow, purposeful way will help quiet what's going on. We have healing hearts, little hearts that are filled with lavender, which is a healing property that they can sniff and smell, that can take to court with them. We sometimes do very careful guided imagery, some that do not trigger, what has happened to them. And there's several other examples here. Think of some that that some of the clients that you've interviewed do, and some that you yourself do. Next slide. Partitioning strategies include commemorative presentations. We ask them to present your loved one. Bring artifacts that tell us about who they were and your relationship with them. We've gotten videos of skateboarding, Mario's pizza, told about mom's cartwheels, shown tennis skills, some jokes that were played, and someone who was begging for back scratching all of the time. This is oftentimes the very first time that we see that participants smile. There's a lightness. There's also guided to keep the presentation on the life of their loved one and not the death at this time. And they're given ample time to do a commemorative. In another session, we will ask them to do a death imagery presentation. And that always follows the commemorative because the commemorative has just reminded them of a lighter part of their loved one. This one may dig into a little bit more stressful and painful. We ask them to draw, not the actual death scene, but we ask them to draw what they keep seeing in their mind, oftentimes that they've not even told anyone else. But what do they keep seeing and picturing? This is an example of someone who's lost their son in 9/11. She accompanied this drawing also with this poem. Questions about 9/11. An old adage reads, "No reason, no rhyme, but tell me, God, was this his time? Why that meeting, that morning, that room, of all the buildings in Washington to meet his doom at the Pentagon? Consulting with 3-star General Maude, proposing a plan they now applaud. Why couldn't he have finished and begun walking away to his car, far, far from that horror of that cruel end? When will I ever mend?" says his mother, Muriel. Next slide, please. One of the co-victims said it this way: "The commemorative and death imagery segments were especially useful for me. The former, the commemorative, because it emphasized to me how many positive things there are to remember about my father. It brought back the earlier times before his sordid death, the times I was so proud of him. The death imagery, because it made me realize how powerful I am, that I can have these horrible images in my head and put them on paper." Next slide. Perspective intervention, that is having meaning and hope for the future. Not finding meaning in the death, but having a meaning and hope for the future. So we ask folks to bring mementos to the last meeting for every member of the group, including the facilitators. They are symbolic representations of their love for each participant to help carry the burden of the story that we've all heard of what happened to them, but also the memory of their life. We also start planting seeds about the survivor's mission, something that they may want to do in the future in honor and in memory of their loved one. Next slide, please. Here's some examples of the symbols that people brought. Harriet brought seashells. He brought 2 seashells, 1 for each parent. He says they lived on board a sailboat and they were killed and buried at sea. These seashells are for their love and for association with the sea. Rose, she's an angel and a butterfly. A rendering an artist did of this drawing of a statue I was given at a funeral for both my daughter and my 10-month-old son. JJ, Japan was my son's birthplace, and he had faithfully cared for a large bamboo arrangement we had left behind when he moved to California. Bamboo symbolism for the Japanese involves integrity with an openness, open for new ideas. Matt was at a point in his life where he was beginning to open his adult life and was ready for new ideas. Hala, my sister, planted corn. It produced 1 ear of sweet corn. And knowing it was my favorite, she picked that ear and gave it to me. Our grandmother instilled Eastern spiritual beliefs in us from her Asian heritage, which my sister expressed through acts of kindness to friends and strangers alike. Kayla said my symbol is a weeping angel. This represents how I felt. I had failed my sister. I had fallen into a deep depression. And Yvonne, in this image drawn and contributed to by my daughter, I'm able to visualize a message from our mother. I never left you. Though you cannot see or touch me, I will always be near you. In your deepest pain and despair, if you listen with your heart, you will feel all of my love around you. Just close your eyes and you will see I have never left you. I am there. Next slide. The criminal death support features include the restorative retelling intervention strategies. It also includes guest speakers from the community. Because it's more of a psychoeducational group, it also asks people to come in for like a half an hour of the 2-hour group, and they are asked to speak about their particular job, their career, and the pushes and pulls in working with a homicide. Also, they are encouraged to give tips if they have them for co-victims that are listeners to their advice. They're coached not to try to attend the different cases in the room, but to present what's going on. They oftentimes will leave their card for any follow-up questions. We'll have folks like a homicide detective. We'll have somebody from the media, someone who's been friendly to co-victims, and their newspapers represent a respectful presentation. We also might have somebody from a faith community, and also perhaps a prosecutor who might be able to explain some of the process or the legal terms. We've also had somebody from MAD who will come in and talk about the legal process in the criminal justice case. This group is heavy on the how-tos, links, and resources. It is 10 meetings, 2 hours, 10 participants, and it doesn't always follow the sequential course. It sometimes gets moved around based on the needs of the group. The next slide, please. Some of the psychoeducational support examples are things that we will do with them are help them to advise them to form an army for safety and support. All of us have teams that we work with. Many of our families can often be alone and separated and isolated. We also encourage and help them to write a press release. They may never have done that before in their lives. We give them some do's and don'ts about the media, including social media. We provide them with links to legal definitions, like what is redacted, what is adjudicate, why the manslaughter charge. We also encourage them to have words that describe their loved one, and what worked and didn't work in the investigation and the legal process. Ask them what do they need to do about, and what do they need to know about grief and resiliency. How is this kind of a loss very different from all other kinds of losses? We encourage them and find ways for them to fill out a victim impact statement, which other agencies do as well. And we provide examples that people have provided for us. We also will provide some information on the courtroom process, like who's in charge, what can you do and what can you not do. And don't bring crinkly candy paper. And also don't wear big buttons with your loved one's face on it. It may prejudice the jury. And what's involved with the prosecuting of the case? And why don't they move forward? We also address the long-term consequences, as Dr. Rynearson was talking about. This is a long-term, this is a reality. When you remove a limb, that's a reality, that will be a forever. When you lose somebody in a murder, it's also a forever change. Next slide, please. Restorative retelling services and adaptions through me and my colleagues have been delivered in many different ways, and the most frequent way it's been delivered is through groups, the 2 10-week groups that I was talking about. Services have been paid by health insurance, victim assistance funding, donations, private pay, and grants. Hopefully, with this new information, that there'll be more availability for funding for this particular kind of specialization. Some colleagues have combined the Restorative Retelling group and the Criminal Death Support group. Facilitators have been clinicians, advocates, peers, and faith community leaders. Groups are traditionally a 10-week process, but some have had 14-week process. Some have been weekend retreats. Some have been provided by individual and couples and family sessions. There are self-help books that will guide them through these processes as well, both Restorative Retelling and the Criminal Death Support. There have been adaptions on services for children. And this process integrates well with other approaches. Next slide, please. Those of us who are caregivers need to practice the intervention in restorative retelling ourselves to reduce our compassion fatigue, the secondary traumatization, and the contagion risks that we may suffer. The structure and process of the group enabled me to listen to the tragic stories without becoming completely engrossed and overwhelmed, says Dr. Charles Moreau. Next slide, please. At the end of every group session, we do a calming relaxation session. At the end of training, I oftentimes will invite folks to take the little bottles of bubbles that I've given them and to debrief by doing the out breath and to blowing out the bubbles, because it's a relaxation response, it's the letting go response. It's also the sigh. Next slide. Now we've added resources for you. Next one, please. This first one is my contact information. The next slide, please. And the 2 workbooks that I said, replicated in a self-help way, 2 books for co-victims and those who work with them. And then the Journey workbook has 7 anonymous survivor contributors, so folks can get a sense of having a group to follow along with if they're working themselves. It can also be useful for peer facilitators to help people go through the process in a lighter version. And in the Murder Survivors Handbook is the Criminal Death Support Group. Can also be used as a guide for leading a group. In this one, there's 100 contributors and 11 anonymous co-victims. Next slide, please. And this is Dr. Rynearson's contact information, and I especially want to point out the last link there is the free downloadable manual for you to use. And the next slide, please. And this is his book, Restorative Retelling, developed out of his own personal experience. I thank you all, and I hope we have some time for some questions from you.
All righty, thank you so much, Connie, Ted, and also Marina and Sarah. I will give everybody some time to type in questions. There's like I said, there's a Q&A box toward the bottom. If you want to go ahead and type your questions there, I will read them aloud to the presenter. So let's hang out for a minute and see if anybody does have questions. All right, well, I don't see anything coming in, which maybe means that everything has been answered in the webinar. But thank you all. Oh, there's one. Okay, there is one question that's come in. Person said, thank you so much. I may have missed it, but could you speak about the structure of the 2-hour sessions?
Go ahead, Connie.
Okay, we begin with a check-in usually to see how people are doing, but we also, in the first part of, I would say the first 5 sessions, we would have some content information that we provide them. And then we will ask a question and go around the circle, ask everyone to reply to the degree that they can. And then we'll acknowledge that. We'll discourage having a lot of questions that they ask one another in the beginning so that they don't feel the pressure to reply. Then we'll do a second question and again go around to each participant. And then we'll close with a relaxation activity and perhaps a poem of inspiration similar to the ones that I read. That will give you kind of a template of the structure of the group.
Okay, there's another question's come in. Can you elaborate more on the narrative reconstruction of the relationship?
You want me to take that?
Yeah.
It gives me an opportunity to talk about triadic conversation. Usually when we are with a patient, there's a dyad that's going on between us and the patient and our 2 voices. But I think there's the reconstructive possibility of aligning ourselves with the voice of the deceased to include them in restoring the narrative of their living and their dying. So that often I'm asking at the beginning of the group about dreams and conversations and how the image of the dying or their loved one has changed over the last week. And as we're going through some of these exercises, I want to hear from the deceased person in terms of their voice. How would Fred feel about your being unable to forgive yourself about his dying? To begin phrasing questions and opportunities to widen and deepen the restorative possibility of the person beginning to change themselves in this narrative. We can't change the story, but I think something almost poetic goes on in terms of a change in their role within the story and their attachment with the person, if we also allow that person to connect with this. And of course, this has gone on for thousands of years with shaman that use these sort of techniques of bringing back the soul of the person, for having a conversation with the person. So that's the other thing I think it's important to emphasize, are some of the creative possibilities of widening and deepening the narrative by using the voice of the person as an ally. How would they help us?
All righty. Next question is, how do you believe victim advocates within a prosecutorial setting could encourage components of restorative retelling within the scope of their practice?
Well, I wish we had Beth Ann Halsnoy and Vilma Torres with us, because they've been using this model since 2000 at the prosecuting attorney's office in the Bronx in New York City. And they would be an excellent person for you to contact. And I think their names and addresses are underneath the resources.
And something I could add here too is that I think that if they're noticing what people are doing that are those resilient aspects of their world, I think that that could be something that would encourage them to also focus not just on the death of their loved one, but also on the lives of their loved one. To ask specifically, who is their loved one? Look at the pictures, like Dr. Rynearson talked about, seeing the photo, or any memorabilia that they're carrying that's a symbol of their loved one. I think those are ways that we can ask, and not always ask the story about how are they doing and what has happened to them.
All righty, yes, Beth Ann's information is in the PowerPoint. And Abby, if you want to reach out to us, we're happy to get that information to you. Like Dr. Rynearson said, they've been doing it for a while. Probably one of the reasons they're not on the webinar is because they've been working on this for years and years and years. So with that, I think we'll let everybody go. Thank you all so much. Thanks to our presenters for sharing your expertise with us today. We really appreciate your time and efforts. And everybody have a great day.
Good to see you all.